talking more about immediate activities that a hospital or health system can do. Others have spoken about the upstream issues. In my limited 20 minutes, I'm going to focus on what hospitals and healthcare systems have been able to accomplish in the short term. So this is about translational work and about scaling up to large-scale effects that have been successful over the last couple of years. Just as a start, maternal mortality is a bit more complicated than many other measures that we use. It sounds simple, death but during or after pregnancy that is related to the pregnancy, but it requires many different medical records and death and birth certificates to actually create the number. It's a small number compared to infant mortality. Just 17 to 23 per 100,000. It is felt to be the tip of the iceberg, though, in terms of representing other maternal morbidities and complications. However, I chair the maternal mortality review for the state of California for the last 10 years, and we've come to appreciate that there are multiple judgments involved with decisions. It is obvious if a woman dies during intrapartum, but it's a judgment as to whether she's even pregnant or pregnancy or tied to the pregnancy if it is months, 2 months, 6 months, 12, 8 to 10 months after delivery, or sometimes very early in pregnancy. 8 weeks pregnant, for example, is often missed. There are many, many causes of maternal mortality when you look at the immediate immediate issues that led to the death. And that is summarized here in this slide with the major causes to the left, the 6 causes, 5-6 causes that are the most common and classically pregnancy related. As mentioned before, these exclude suicide, homicide, and substance use disorders. And there also excludes all the myriad of medical complications that can cause death. But for the 17 per 100,000, these causes of death individually are only 1 to 2 per 100,000 women, making it very difficult to study and actually difficult to show impact. Cardiovascular disease is the one exception, but that's still 3 to 5 per 100,000. So we've turned our attention to severe maternal morbidity, the CDC definition, which occurs almost 2% of cases. 180 per 10,000 births is how it's often reported. But here the individual causes are still pretty rare. Blood clots or thromboembolism, 3 to 4 per 10,000 births. Infectious deaths or sepsis, 9 per 10,000 deaths. The two that have the most common frequency for severe maternal morbidity and account for the large majority are hemorrhage and preeclampsia, and they're also the most preventable causes of maternal mortality. And therefore, they have gotten the focus of most of the interventions that we have done clinically. But even looking at hemorrhage, that's comprised of multiple causes. You have uteroanatomy, which is very different from the approaches you take are very different from placenta accreta or very different from ectopic pregnancy. And so it gets smaller and smaller bites of the intervention approaches. Cardiovascular disease, for example, is also divided into multiple causes, where cardiomyopathy, which presents very late and often months after delivery, is a very different approach to women than to women with known congenital heart disease. In addition, each of these major causes of mortality are embedded into layers of contributing factors. These include quality of care, multiple comorbidities, has been mentioned previously, and also social determinant, and often on an undercurrent of racism. And the amount of the thickness for each of these factors can vary. For example, for hemorrhage, there's a lot more quality of care issues and less social determinants, whereas for hypertension, all these factors come into play in very large degrees. Racism can affect in many different ways, and it's going to be talked about in future presentations, so I'm not going to dwell on these, but we've seen this as a very important undercurrent for the quality of the care that's provided for women with any of these conditions. So the main thing I'm going to speak about is how do we translate best practices or known consensus guidelines into actual care to where it can have impact. This is a famous article from the New England Journal talking about how that transition is lost in translation. And this has stuck with me for my entire career, that it takes 17 years to go from consensus guidelines to integrated clinical practice. This is not tolerable for any area, but particularly as we talk about maternal mortality. So I'm going to talk about our experience in California, which is the size of an entire country, 40 million people, as many births as most European countries, most big European countries, and it actually accounts for 1 out of every birth in the United States, all within a single administrative unit. We have 4 major urban centers, as well as great diversity in rural areas, not only farms, but deserts and mountains that all create their own challenges for care. CMQCC, which is the project that I lead, was founded in 2006 as a response to the rise in maternal mortality rate in California. We did not have a maternal mortality review committee prior to that time. As the chair of that committee, I was able to use the findings of our reviews to drive our state quality improvement efforts. And this is a really important thing. To review to action is the mantra of the CDC in all steps going forward. So the 4 key things that we've been able to harness is partnerships, rapid cycle data, quality improvement toolkits and bundles, and large-scale quality collaboratives. I'm going to talk about those briefly going forward. So our mantra is you got to partner with everyone. So that includes all the state agencies engaged, all the membership associations, such as our hospital association, our business groups, our other quality organizations in the state, all of our health systems, Kaiser's, Sutter's, Sharp, Dignity, et cetera, our professional organizations, ACOG, Women's, A1, the Nursing Association, the Midwife Family Medicine, Anesthesia, others, as well as a group of public, consumer, and community organizations, a few of which are listed here. And importantly, in recent years, the importance of harnessing the pressures and incentives that health plans, both Medicaid health plans and commercial health plans, can bring to bear for improving outcome. None of this is really possible without rapid cycle data, though. And this is, our mantra in California has been free the data, and our State Department of Health has been very forward-looking in this. And we are able to receive a feed of birth certificates every month for every birth in California that occurred in the previous month. So 30-day-old data combined, de-identified, but combined then with hospital discharge diagnosis files gives us a foundation of data that is enables us to engage our hospitals and to drive quality improvement efforts. So this has been a foundational piece. This is low burden, low cost, and really provides high value information for every hospital in California, all 230 odd hospitals. So this is then combined with quality improvement toolkits. Toolkits are a implementation guide, often 70 to 100 pages of examples, policies, procedures, as well as guides for how to implement the national safety bundles. And we've been working very closely back and forth in terms of authorship with the AIM National Safety Bundles for hemorrhage, hypertension, prevention of cesarean births, so that each bundle, which is only about 2 pages, basically a checklist of things that each hospital should have, is partnered with a toolkit for how to implement it. But a bundle or toolkit doesn't go anywhere, and as was mentioned previously, there's a lot of concern about how a bundle actually gets implemented. And so our approach is to do large-scale quality improvement collaboratives based based loosely on the IHI Breakthrough Series, but with mentors and other approaches involved to engage large numbers of hospitals at the same time and to do these repetitively in our state. So it's not just one collaborative that we've done once, but a series of collaboratives basically every couple of years that last 18 months each, that have engaged essentially every hospital in the state, generally in multiple times over the last 10 years. And we've seen change. So this is a maternal mortality ratio in California. From 1999, we started our maternal mortality reviews in 2006, and our first really large-scale implementation projects were 2010 onwards, and we're still running collaboratives today. Examples of these are shown here first with reduction in severe maternal morbidity, the CDC measure, from a large-scale collaborative over a couple of years that involved 300,000 women in California, 99 hospitals. We had before and after, as well as comparison groups of folks who were not in the collaborative, and could show that there was a 20% reduction in severe maternal morbidity in participating facilities and a 1% improvement in the comparison groups. And actually in facilities that had done, it was their second attempt at participation, their second round, they had a 28% reduction in severe maternal morbidity. Another recent example is our collaborative to reduce primary cesarean rates, which has been a tough nut in the United States to address over the last 20 years. Cesarean rates have risen 50% in that time period without any clear benefit for either mother or baby. And now we have an epidemic of mothers with prior cesarean births, and this is the driver for placenta accreta, which is a major cause of both very large hemorrhages and maternal death. But hospitals have huge variation in care. Rates range from 14–15% to 50% or higher for first birth low-risk C-sections. And there's racial disparity in C-sections, with Black women having a 6 percentage point higher rate than white or Hispanic women. So we undertook a 2-year collaborative that touched every hospital in the state and got very significant reduction. Again, California started off the same rate as the United States, around 26% for first birth low-risk C-sections. And over the course of a supporting vaginal birth collaborative combined with statewide activities, we brought that down to 22%. The green line here represents a balancing measure, which is what one does for any large-scale quality improvement project, which looks for unintended consequences. And here we were wanting to measure significant term newborn complications, such as such as sepsis, head injury, birth injuries, requiring head cooling, intracranial hemorrhage, any of those major effects. And those actually improved during this time period from 20 to 14 per 1,000 births. So that was very reassuring. How does one accomplish change at scale? And it's about pulling multiple levers at once. So in our statewide initiative, we not only on the left-hand side had data-driven quality improvement, had professional organizations involved, had the QI toolkits that I mentioned, direct participation of women engaged in this process, but we also did public reporting. So this was now one of the transparent measures for the state on websites, but also in our Secretary of Health and Human Services for the state of California gave awards to hospitals that met the C-section rate the national targeted C-section rate. Purchasers and employers were involved. They gave incentives to participate and wagged their fingers saying that they were concerned about this topic and that would impact future contracting. The same was true for our Medicaid. We had 1115 waivers. So for public hospitals and district hospitals to participate and actually incent it. And so this was multiple people talking at the same time on the same topic with the same target. And that was really important and can lead to the type of statewide changes that you're seeing on the left-hand graphic here. Now, when we looked at effects by race and ethnicity, we saw that there was still about instead of 6% difference, we had reduced it to 4%, but there was still a difference. And even when you looked at individual hospitals, and this is our data center showing a report, and the hospital was doing great, 22%, but there was black-white differences that were astonishing. White women were 19%, Black women were 28%, Hispanic women varied significantly as well. This hospital had no idea. And in fact, most hospitals have no idea about what their outcomes are stratified by race and ethnicity. And this is one of the major interventions that we're bringing to bear in California. Fast forward, as this hospital has worked on these issues over the ensuing 3 years, we could see that their Black rate came down from 28 to 22. Still a difference, but that difference was narrowed. And now we're working on equity issues at the same time as clinical issues. And that's it illustrates a couple of key points that hospital provider feedback are very powerful. Care decisions that high degree of subjectivity, such as decisions to do C-sections, provide significant opportunity for bias, both explicit and implicit, to creep in. And so then the third key observation is the more change levers that can be pulled at once, the greater the effect. So how do we scale this up even higher? And we've moved to engage national partners in this effort. The Joint Commission has actually adopted the key elements of the hemorrhage and hypertension national safety bundles as standards for use for accreditation. Now that's a pretty powerful force. And so when reviewers come to every hospital in the state, they'll be looking to see if these bundle elements have been adopted. Just to about 2 months ago or less, Medicare issued new rules for the inpatient quality reporting program, which is used for Medicare, but also so therefore for every hospital, but it has incorporated 1 or 2 obstetric measures. And the new ones are structural measures. Does your hospital participate in a statewide perinatal collaborative? And number 2, have you implemented the safety practice related to the bundles? So this is a clear step forward. Also, in scaling up, HRSA has introduced the AIM project, which is supporting statewide perinatal quality collaboratives to implement these projects on a statewide basis. Their national partners are basically every organization is involved in maternal health, but the real work is done at the state level. And the states now engaged in AIM are 42 out of the 51 states in the District of Columbia, with another 5 going to be joining this year. Now, all of these are at very different levels of engagement. California is one of the oldest ones, as is Illinois, New York, and Florida. But some of these are brand new. And it does take 5-10 years to really get the momentum going. The CDC is providing funding, hopefully for more than the 13 states that they're currently done. So I'm encouraged that this is the ability to then affect change at scale. So in conclusion, we think these are the keys for improving care at scale. The public health surveillance data, such as maternal mortality and patient stories, create a burning platform for change and drive actions. You have to have that burning platform for hospitals and providers to pay attention. You have to mobilize every possible partner in this, and they have to drive change together. You need rapid cycle data to support and sustain QI projects, particularly at scale. And you have to have large scale quality improvement projects to implement the safety bundles. Safety bundles in and of themselves don't change anything. You have to have people working together to make that change happen. And as I said earlier, you got to pull all the levers at once, hospital and external. And what we've learned is that you actually have to have equity projects together with clinical QI when you're going to change and improve the care for all mothers. So Yoel, I'm going to turn it back to you, and thank you.